I'm going to completely change gear. I'm not going to talk about coagulation at all. I'm going to talk about transfusion issues for African children. Why is this an issue? Severe anemia is a very major cause of hospital admission in African children. Up to 15% of children coming into hospital in sub-Saharan Africa have severe anemia. The etiology is multifactorial, but it has infection as one of the cofactors. But outcome remains poor. In-hospital mortality is around 6 to 8%. But if that doesn't capture the entire event, for those who go home, between 10 and 14% will be readmitted or die in the 6 months following. We'll move on. So why is this a problem? So if you actually look at the standard pattern of use of blood in, for example, a UK system, a lot of it is often pre-planned, it's largely predictable, whereas in Africa this is completely different. 60% of the use of transfusions are by children. And so that represents a huge slice, and most of those are unpredictable. They're for emergencies and often seasonal, especially with a huge demand during malaria seasons. Why is this an issue for Africa? Although WHO suggests that between 20 and 30 units should be donated per 1,000 population, in most of the countries in sub-Saharan Africa, you can see donations are less than 5%. Over the last decade, there has been a substantial strengthening of transfusion services, but this has not improved the actual donations. So outside of South Africa, most of the countries only collect less than 5 units per 1,000 population, so there just simply is not enough blood. So how did WHO define severe anemia? You'd probably be quite surprised about this, but they define it as a hemoglobin between 5 and 6, severe anemia, or a hemoglobin below, which that should be 4 and 6, or a hemoglobin below 4 is profound anemia. Severe and complicated anemia, that's sort of dropped off the thing, is a child with a hemoglobin between 4 and 6 with evidence of complications, impaired consciousness, respiratory distress and/or shock. So there has been a couple of Cochrane reviews, and the last one was done in 2000, and both have suggested that we need to do a transfusion trial. This is the only data that was assembled before then, suggesting that compared to if you've got a hemoglobin cutoff of 6 or below, you have a much higher mortality compared to children admitted with a higher hemoglobin. Obviously, the conduct of research in other parts of the world have brought transfusion thresholds down to, obviously, for stable patients in ICUs of a transfusion threshold of less than 7. So it emboldened us to be actually able to say, yes, we do need a controlled trial in Africa, testing under the conditions in Africa, where we're concerned that who needs blood, but also for the WHO recommends a standard dose of transfusion of 20 mils per kilo of whole blood. But we know from the reanalysis of the FEAST trial data that actually 30% of cases that actually received 20 mils per kilo had to go on to get a second or even a third transfusion because it did not correct their anemia. So that's, again, overuse of a very, very scarce resource. So the two transfusion questions that obviously were sort of quite obvious is that the first one was who needs a transfusion. For that group between 4 and 6 who are stable, they're recommended not to receive a transfusion. So the question is that we don't know whether we could improve outcomes by actually transfusing those children. The second question was how much blood to give, because as I've just shown you that 20 mils per kilo, if you use a standard calculator looking at deficit correction, it simply does not correct the deficit, meaning that you're going to have to go back and use a second or third transfusion, increasing the risk of obviously transfusion reaction, but also B, overusing a supply. The other question about, rather than just narrowly focusing on that immediate question, is that the downstream outcomes of these children are very, very poor. We know that bacterial infection and nutritional deficiencies such as vitamin B12, vitamin A, are major causes of severe anemia and also lead to poor prognosis. At the moment, apart from a transfusion, children are recommended to receive iron and folate and nothing else. So we wondered whether giving a better micronutrient supplementation would improve outcome compared to the standard, and whether giving antibiotic prophylaxis would improve outcome. So how do you design an optimum trial? We've got all of those questions that we want to ask. And what we tend to see is there's an A versus B question, but there's in this transfusion sort of scenario, we want to actually ask more questions. And so we conducted a factorial trial in which for each question that you want to ask, somebody gets randomized between each randomization. There's obviously various options for that. Why is it good that we do factorial trials? Well, they're efficient. Setting up a trial costs a lot of money. It costs a lot of resource, in terms of time, but also, obviously, it's very efficient if you ask more than one question in a clinical trial. Obviously, that means you have to inflate the sample size, but then that allows you to investigate what we would say is a bundle of care, but effectively that represents what patients are doing. So it allows you to control for what everybody else is, other things that actually happen. So there's nothing more complicated than medical practice, and that's how we justified this to the MRC who funded this trial, the TRACT trial, transfusion and treatment in children with severe anemia. So what were our transfusion randomizations? So we remember those two questions. We've got two strata based on the severity of the patient. In the first strata, or strata A, that's severe and complicated anemia, based on whether you had a hemoglobin below 4 or a hemoglobin between 4 and 6 with a complication as either respiratory distress, hemoglobinuria, which is basically black water fever, or known sickle cell disease. For the children between 4 and 6, the standard of care arm is no transfusion. And what we were saying was whether actually if you're going to receive a transfusion, whether a higher volume or a lower volume. So they're asking two separate questions in that actual group. As you see that the transfusion volume question is across the whole, those two strata, and then just who needs blood is just for the hemoglobin between 4 and 6. The long-term interventions that we selected, this is something called Sprinkles, which is a multi-mineral, multivitamin powder that's already on the market, and so we tested that against iron and folate. But we also used cotrimoxazole as infection prophylaxis. It's in HIV, it's rolled out as a standard. It not only protects you against bacterial infection, but it also has an anti-malarial property as well. So that was our 4 separate randomizations, all at admission into the trial. So I'm just going to talk, because this is a transfusion session or something around that, I'm just going to talk a little bit about the transfusion outcomes. We didn't want to just look at in-hospital mortality. We wanted to look at 28 days. Although the funders said you couldn't possibly do that, we did. And so that was our primary outcome, which is a fairly robust one. Secondary outcomes include early mortality and also mortality all the way through to day 180, plus a number of other aspects, hospital readmission being a really important one. So we did a transfusion trial to underpin the safety of this, because we just finished the feast trial when we put this in, and people were very concerned. Well, you've shown by giving volume to children who are critically ill is harmful. We're concerned that giving a higher volume of whole blood may be harmful. So we actually tested this in a phase 2 trial, and it has been reported in this paper. And while we actually showed that those receiving the higher volume of 30 mils per kilo compared to the standard recommended had a much superior global correction of hemoglobin, we also showed that it was actually the transfusion of 30 mils per kilo is safe and not associated with any adverse events. So we'd done the safety study, we got the funding. The next thing was to what we call operationalizing the trial. So I just want to come back to some of the things that happened in between us obviously designing the trial and getting the funding, which took quite a considerable time, that there had been some obviously strengthening of blood transfusion services. You've heard me talking about whole blood, and you think surely people can't be still using whole blood in Africa, and this is exactly what the external strengthening came in saying, I can't believe people in Africa are still giving whole blood. We know that giving packed cells is safer. But obviously that comes at a cost and a considerable cost in the countries. This is the issue that we have to deal with every single day in Africa. It hasn't improved that issue. Certainly in our controlled trial, we stopped enrolling and randomising on days when we had stockouts. You can't ask a parent of a patient to sign a consent form saying your child's going to go into a transfusion trial and then saying, oh, sorry, the transfusion services ran out of blood. So we actually halted recruitment on those days. We also had to put in implementing, we had to measure everything. We recorded absolutely everything. We recorded the unit of packed. We actually recorded the hemoglobin of the packed blood, the blood, and also the hematocrit. We also had to bring in special burettes to allow us to work out what was being given, the volume that was given. We were also weighing the packs as well. So we obsessed about absolutely everything, and we also did very, very obsessive training. It was a very difficult trial to actually to roll out. And normally what you have for any investigational product is a certificate of analysis. Now this does not come with a certificate of analysis. So just before we started the trial, we did a pre-trial audit of what actually we were doing, because we took a drop of blood just before we agitated the pack and obviously ran it through the burette. And just before we actually connected it to the infusion line, we were able to look at hemoglobin and hematocrit in these different packs. So first of all, we had to learn what local terminology was, that most of these blood transfusion services simply did not have enough centrifuges to actually create packed cells, or what was thought to be packed cells. So they actually settled them overnight by gravity to actually produce red cell concentrates. So we had obviously multiple different things that were, some were set, red cell concentrates were gravity settled, and others were by centrifugation. And that just really says that, and clinicians don't know anything about this. As far as they're concerned, it's a pack of blood. They didn't know that actually the pack of blood that they were receiving was either whole blood or red cells. So in terms of, for our trial, we had to educate our doctors about, what was what. We've actually reported this in a paper recently, and I'm just going to give you some of the results to start with, because when we actually, obviously for packed cells, you'd have expected that the hematocrit was substantially higher than whole blood. And so we were trying to work out, well, what's going on here? And the actual transfusion services weren't labeling the actual packs. So when we looked into this, we were saying, well, why don't you? And we said, well, we've never been told to. And he said, well, a packed unit is completely different from whole blood. You need to be labeling your transfusion. So we actually had to do quite a, for the National Transfusion Service in Uganda, had to actually make it much, much clearer which was which, because on the ground we didn't know. So that was obviously a quality improvement. There's been a lot of studies around whether the harmful effects of giving transfusion and the fact that actually thresholds have been brought down, is it due to the age of blood? There's obviously no, I think that in the final sort of analysis that actually there's no evidence in a setting where you have leukocyte reduction. There is no leukocyte reduction in this blood. And so we obviously wanted to, as I say, we recorded everything, and we were able to see what are the sort of age of packs of blood. And what would be called old blood in most services would be from the patient time that you collected the patient to when you transfused, over 21 days. So almost a quarter of our packs that we were using were old blood. And remember, they're not leukocyte reduced, and often they've not been stored in the context that you would normally store in a health service here. blood, so this, once again, the blood that we were taking were from obviously adults or older children. This is what the transfusion service is. But remember, in this setting, there's a lot of people that have alpha thalassemia, G6PD deficiency. Most of them not diagnosed at all, that will have survived to adulthood. And so these have a much shorter red cell life. They have a higher turnover. And so again, the context of this trial is unique to Uganda. This is although we have genotyped the blood, this is just the sort of suggestion that over 50% of blood that we're transfusing will have alpha thalassemia. As I said, the red cells don't last as long. We also, because there's no decent hemovigilance that was actually being practiced in Africa, we actually also tried to ensure the right blood to the right patient and put that system in a sort of modified version of SHOT, which is what the UK recommend for hemovigilance. So I'm able to report this is from an interim analysis halfway through, that actually we were very surprised, even though there was no leukocyte reduction, that we were actually seeing very, very few transfusion reactions. We obsessively monitored for these, and obviously we were concerned that, certainly that some of the bad outcomes that we had seen might be due to this, but certainly there didn't seem to be much evidence of transfusion reactions, which was quite surprising to us. The paper's under review, and so I'm sorry I can't give you the results, but I can give you some little sort of hints of how do we do the trial. Well, once again, I can thank obviously our PIs and the trial teams that out of nearly 4,000 patients enrolled, we had only 3 minor violations, which is just outstanding. 100% adherence to the randomisation. These are the excellences of clinical trials, and we did an excellent clinical trial. So in terms of obviously adherence for volume, which is obviously we struggled with in terms of actually making sure that they got the right volume, but again, once again, 98% adherence. MRC suggested that we wouldn't get, completeness of follow-up to day 28. We would lose a lot, but we only lost 3%. So we, in terms of the primary and secondary endpoint to 6 months, we had a fantastic retention. So once again, good trial excellence. I don't know whether this is coming across very well, but it's quite eye-watering when you look at, you see that the severe and complicated arms, the median hemoglobin was 3.8. I mean, I think if you had a case like that presenting here, you'd probably make a case report out of it. But, it's a sizable group of children. The other thing to point out is that while sickle cell anemia was all meant to be, with known diagnosed sickle cell anemia, we actually had about a third of the patients in the severe and complicated arm. They were all meant to go in there. When we genotyped the kids at the end of the trial, or we did a batch genotyping, nearly a quarter of the children in the other strategy had undiagnosed sickle cell disease. So this is a phenomenally large population, and they're a very, very major population requiring blood transfusion. As I say, the paper's under review, but I'm also very proud of our representation at the front of and at the back of the authors of lots of girl power. If anybody's interested in this, we've already published the trial protocol, and we hope to be able to hope that the paper will be accepted and you'll all be able to read it in the next few months. Thank you.